Pär Stattin, prostate cancer mortality in areas with high and low prostate cancer incidence. Please.
Thank you. First, I have an announcement, and although I'm very enthusiastic about the interest in statins overall, I have no interest regarding these drugs, so no conflict of interest. I'm going to present some data on a study on prostate cancer mortality in areas with high and low incidence, and it's a collaboration between Swedish researchers in Sweden and at MSKCC. And let's see if I can. The data sources we have used here are the Swedish Cancer Registry, the Cause of Death Register, and the National Prostate Cancer Registry of Sweden. And all these registers have been shown to be very complete, above 98% of all cancers in Sweden. Here you see the prostate cancer incidence and the mortality in Sweden. And as in many other countries, has been a rather steep increase in the incidence, whereas the mortality has been rather stable. Now, we previously investigated the predicted and observed prostate cancer incidence in Swedish counties. The predicted incidence is the lower curve here, based on if nothing has happened from the 80s and going on. And here is then the observed incidence, which occurred due to PSA testing. And for instance, here, Jonas, you see the incidence in Gothenburg, that rise pretty sharply. And here is the county of Västerbotten, where I'm from, also a pretty sharp increase relatively early, whereas in several other counties, almost nothing happened until the late 2010. So, in order to use this sort of natural experiment, I'm now going to show you the data which we have then investigated on a group of high and low incidence counties. So here is then the difference between the observed and predicted incidence, and we then took the 8 counties with the highest incidence, where we can assume that there has been a lot of PSA testing starting relatively early and rising quite rapidly, compared to 6 counties where only in the very late in 2008-2009 there was an increase in the incidence, thus suggesting an increase in PSA testing. So here, just to corroborate, we see here the incidence of prostate cancer in these 3 county groups, and as should be expected, then the PSA testing group is the highest. We then move on to see the incidence of prostatectomy and radiotherapy in these 2 groups. You see that the incidence of prostatectomy and radiotherapy was highest in the PSA testing group. If we then look at the median PSA levels from the NPCR at the date of diagnosis in counties with high incidence and low incidence, you see it in year 2000, the median PSA was 10 in the high incidence counties and 18 in the low incident counties. And then when we come to 2009, these differences are virtually gone. So there's been a catch-up. This is an important factor, a technical detail of our analysis. We did an incidence-based mortality analysis. That is, only men that were diagnosed after year 2000 were included in the analysis, since these were the only men that could possibly have an advantage of PSA testing. Men who had been diagnosed before that date couldn't possibly have any advantage of the PSA testing. And this is a busy slide, and the bottom line is that we had a huge number of cases, 4.5 million person years in the high incidence counties, with about 1,500 prostate cancer deaths, and in the low incidence counties, about 2.5 million person years at risk and about 980 prostate cancer deaths. And so here you see the incidence of metastatic prostate cancer in the 2 groups, with a lower incidence in the counties with a high PSA testing. Then we go to the prostate cancer specific mortality, virtually the same difference. We then use excess mortality, which is then the mortality among with prostate cancer without, regardless of what the cause was for death. And here you see an even stronger increase or difference. And here are then the hazard ratios for the PSA testing counties, high incidence counties versus the low incidence counties. For all these three measures, around 0.85, 0.87, 0.77. And we then looked in the group of 55 to 69-year-old men, the core group of the ERSPC, and found basically the same kind of decreases. We then looked at the temporal changes in the high and low incident counties and found that the decrease has been strongest in the high incidence group, looking at 2000 to 2009 versus the earlier period. There had been a decrease also in the low incidence counties, but of a smaller size. So in conclusion, early detection and treatment decreased prostate cancer mortality in a rather modest number, I would say. And so I think the next step is to try to understand how to avoid overdiagnosis and overtreatment. Thank you.
Thank you very much. And thank you very much. Any question? Yes, Peter.
Pär, that's an elegant study. We did virtually the same thing when we compared Seattle and Connecticut about a decade ago, which we did not find any difference, but that was a good decade ago.
I'm well aware of your studies, yes.
No, I'm sure. So the question becomes, what's the cause and effect mechanism? Because we know in the US you're seeing a decline in prostate cancer mortality, and most of the modeling shows us that about half at most could be attributed to the screening and treatment, which means another half is due to something else. And the question is, if you're seeing decline, is it a direct result of screening and treatment? Have you gone the next step to see whether a higher number of radical prostatectomies or a higher number of radiation therapies that might explain the decline? Or could it be that most of Stockholm is now on statins because they've been adopting things earlier, and because they're on statins, the mortality rate has gone down? Be curious to see what you say.
I think we are in a good position to detect a difference because we have had extremely low rates of testing. So we had rather big differences. And we also, I mean, you saw there were, even in the high incidence counters, the median PSA levels were quite high, according to US standards. So I think we have a fortuitous sort of a scenario where we had groups with large or high risk of prostate cancer death, and then there was a relatively large increase in the PSA testing.
That's not quite my question. No, it's a part of the question. I have no doubt that in your probably wealthier counties is probably where the increased testing occurred. Am I correct in that? Or slightly more urban centers where picked up the testing earlier. That's what I suspect. So the question is, have you gone the next step and asked, has been the rate of radical prostatectomy dramatically higher, as we saw in Seattle compared to Connecticut? Was the rate of radiation therapy dramatically higher in your 6 counties that did excessive testing? And does that in turn translate into your excess or improved mortality? So in other words, taking all the steps of screening and treatment and documenting that you have increases so you have the cause and effect. Jonas is maybe making a comment.
Well, as I showed you, there was a difference. It wasn't huge, and it was sort of transient, but that's the best answer I can give you, really.
I agree that there can always be differences, but I do not believe that there were differences, for example, in statin use, because I think in Sweden it's not like that. That I would not guess. What I think maybe is, if we compare to your studies, what we say is high incidence counties would maybe be what you call low incidence counties in the United States, because the uptake of screening in Sweden, I think, is much lower and much coming later compared to the US. You have such a dramatic top, while it becomes more like this in Sweden. So I think the high counties are more like Connecticut in the US.
And I think another point is it's not really affluent versus less affluent counties, I wouldn't say. I think we can very often, I think, pinpoint sort of urologists that have been very influential in the type of PSA testing that has been used. And Stockholm, in fact, had a very late increase in PSA testing. So I don't think it's so easy you can say affluent, less affluent. It's rather that it's been sort of a different attitudes among urologists that has sort of translated into different patterns of PSA testing among family physicians.
But great study. The question, what is the influence of the RSPC at that time? So in those counties that were part of the screening program, how did that translate in the breakdown?
Well, that's in one of the 24 counties, and so I don't think that would affect the risk estimates anything.
Neither do I, but I heard one question. We talk about radical prostatectomy and radiotherapy, and we say 50% of the decrease in mortality would be due to screening. But, I mean, screening is a prerequisite for the changing in therapy we see. Because back in the 80s, when myself and Gunnar Haus looked on this, of those detected in the 80s, only 10% were detected at the stage where radical prostatectomy were even possible. So I think this change in therapies, of course, therapy is the important thing, but we need an early detection for changing the therapies. Otherwise, we will not come.
But I think it's fair to say the precise mechanism remains elusive.
That's-
It's either earlier treatment, more treatment, or something else that we don't know about, due to a selection factor from the populations you studied.
But how can you possibly disentangle them? You
Well,
can't do
that's
early
the
treatment
question.
without early diagnosis.
We didn't ask you to disentangle them. I was just questioning, I think your
But
study...
can you ever do that? Because an early treatment will be associated with early treatment. Dr. Lilja is...
Okay, one more, and then we'll move on.
Just as a comment to this suggestion, because actually some of the registers and some of the data that are feasible to access under with the type of IRB waiver, I think can at least help to address this, namely the individual who had PSA testing, linking them to the treatment given, and also the same for statin medication and the same. Because the health system that we have available and the registers that are in Sweden and other Nordic countries allows for this.
Okay. So just one point that's worth observing is that, again, incidence isn't going to serve us very well as we go forward in the future. As new diagnostics replace old diagnostics, we'll be identifying fewer patients, but a greater proportion of men with high-risk disease. And so if we just continue to follow incidence, it will go down, and we'll miss the kind of goodness that we'll get from the new diagnostics. So just a point as we go forward. So thank you very much indeed.